I am thrilled to have you here today because we're going to be stepping directly into the shoes of a clinical detective. We are systematically investigating polymyalgia rheumatea. It's an often debilitating condition that can just drastically impact a patient's quality of life. So, let's go ahead and dive right in. Before we even start gathering our first clues, just keep the sheer scale of this condition in the back of your mind. This is the second most common inflammatory rheumatic disease in the elderly. That means if you are stepping into a clinic, especially anywhere in geriatric care, you are absolutely going to encounter this. It's not some fringe textbook-only diagnosis. It's a very real, very common condition that you need to be perfectly equipped to spot. Okay, here's our roadmap for the investigation. We'll fit epidemiology, symptoms, diagnostics, the differential diagnosis, and finally wrap up with treatment. Starting off with Section 1, epidemiology. Let's take a look at our usual suspect. Now, while the exact cause remains a bit of a mystery, there's a really strong genetic predisposition linked to HLA-DR4. And demographically speaking, the disease shows a massive gender divide. It affects women at a 3-to-1 ratio compared to men. We also see this presentation a lot more commonly in folks of Northern European descent. So if you're picturing the most likely patient to walk through your door with PMR, you're generally looking at a woman of advanced age with Northern European ancestry. And here is your first major clinical pearl. The typical age of onset is over 70. In fact, it is incredibly rare, like needle in a haystack rare, to see PMR in patients under 50. Age is a massive clue here. If your patient is 40, PMR basically drops right to the bottom of your suspect list. Moving right along to Section 2, symptoms, let's examine those clinical clues. These patients typically walk in with a really distinct dual threat mix of symptoms. On one side, you have the systemic issues. We're talking constitutional B symptoms like fever, weight loss, night sweats, profound fatigue, and even a noticeably depressed mood. But then, on the other side, you've got the musculoskeletal symptoms. You're looking for a new onset of severe, symmetric pain hitting the shoulders, the neck, and the pelvic girdle. This pain is uniquely worse at night, and it's paired with this intense morning stiffness that lasts well over 45 minutes. They often tell you they feel completely locked up when they try to roll out of bed. All right, part 3, diagnostics. Let's verify the lab evidence. If there is one standout diagnostic threshold you absolutely must commit to memory, it's this: an intensely elevated erythrocyte sedimentation rate. We are specifically looking for an ESR screaming past 50 millimeters per hour. When you see that highly elevated inflammatory marker paired with an older patient suffering from bilateral shoulder pain, the alarm bells for PMR should literally be ringing in your head. Supporting lab clues help build our case even further. You'll often find elevated CRP, leukocytosis, and normochromic anemia. If you use an ultrasound on the affected joints, you'll frequently spot bursitis. But, crucially, and you can't forget this, no autoantibodies are present, and the serum creatinine kinase, or CK, remains totally normal. In this case, the negative space is just as important as the positive findings. Section 4, differential diagnosis. It is time to eliminate the imposters. This is absolutely critical. Our biggest challenge is distinguishing PMR from its highly dangerous partner in crime, giant cell arteritis, or GCA. And the tricky part? It coexists in about 10% of PMR patients. While PMR causes that symmetrical joint pain and synovitis we talked about, GCA aggressively targets medium and large arteries. That leads to severe temporal pain, jaw claudication, and a terrifying 20 to 30% risk of blindness if you leave it untreated. You have to routinely evaluate your PMR patients for GCA symptoms because the stakes are just incredibly high. We also have to logically rule out other joint and muscle lookalikes. Rheumatoid arthritis might seem similar with the joint pain, sure, but RA would show a positive rheumatoid factor or anti-CCP antibodies. What about polymyositis? Well, that causes muscle issues, but it would present with an elevated serum creatinine kinase. And remember, PMR has a normal CK. And finally, we can cross off fibromyalgia. Now, these patients also complain of widespread pain and fatigue, but fibromyalgia presents with completely normal laboratory values. PMR, on the other hand, lights up the lab with that crazy high ESR over 50 and the elevated CRP. Which brings us to Section 5, treatment. Let's solve the case. The treatment protocol is honestly beautifully straightforward. Step 1, you initiate low-dose oral glucocorticoids. Step 2, you monitor them for rapid symptomatic relief. And this usually happens quite dramatically within just 2 to 4 weeks. Patients will literally call it a miracle. Step 3, if they improve, you slowly taper and eventually stop the glucocorticoids. But if there's no improvement after 2 weeks, or if they happen to relapse during that taper, you simply increase the dose. It's a very clear, logical algorithm that provides tremendous relief for the patient. As we close the book on this case, I want to leave you with this final provocative thought. How will that crucial link between PMR and giant cell arteritis actually influence your patient evaluations going forward? Knowing that 10% of these patients carry a hidden, severe risk of blindness from an associated condition should absolutely keep you vigilant. Always, always ask about those headaches and vision changes. Thank you so much for watching this explainer. Keep your curiosity sharp, and we will see you next time right here on Med Medicine.